Hi there, welcome to Ask the Chiropractor, your source for ultimate health, healing, chiropractic, and medical-related information. I'm Dr. Adam Rodnick out of Commerce Township, Michigan, and I'll be your host today. We're here with our co-host, Dr. Ruvayn and Rubinstein out of Troy.
How are you?
Good to have everyone here. And our special guest today, orthopedic spine surgeon, Dr. Louis Radden.
Hey, nice to see you.
Welcome.
Thanks for
Absolutely.
having me on the show.
Absolutely.
So I want to start off first asking you, I know most people are under the impression if you go to see a surgeon, you go to a surgeon for a consultation, you better just get ready to jump on the operating table. And I know that that's far from the truth. And if you could elaborate on that a little bit.
Well, as spine specialists of Michigan, we're a comprehensive spine center. And actually, our approach is quite the opposite. We actually believe in starting off with conservative care first. This would include any type of physical therapy, chiropractic care, or even aquatic therapy. If the patient fails the conservative modalities, then at that point we talk to them about pain management procedures, which would include any type of epidural steroid injections, facet injections, or even a spinal cord stimulator if they've had previous back surgery for failed back syndrome.
So in your practice, surgery's a last resort, not a, hey, you're in my office, here's the knife, let's get you on the table.
That's correct.
And that's definitely a big common misconception. I know that a lot of our patients fear that if they're going to go to a surgeon, they're already at the end of the road, and that's not the case. We send patients out for orthopedic evaluation just to get a baseline, have them evaluate and co-manage with patients as well.
That's correct.
And I like your philosophy, and that's how we feel as well, that it doesn't hurt to go natural first, drug second, surgery last, instead of surgery first. And so I'm glad that you feel the same way, that conservative care is good to start with, and then a lot of times they may need more, and they may need surgeries as well.
That's correct.
Yeah, I mean, co-managing, like you were saying, that's what's huge. And a lot of people, they think that, I hear people all the time, oh, you know, I went to my orthopedic, I've had surgery, and I can't go to a chiropractor anymore.
Well, that's actually, that's not true as well. Even post-operatively, I'll send patients to Dr. Rodnick for myofascial management. There's a fair amount of swelling and soft tissue pain, and these things can be manipulated even if the patient has had back surgery.
And that's a misconception again too, that after there is a surgery, obviously we're not going to do on that patient the same thing we may do on someone who hasn't had that surgery. And so that's where the misconception comes from, that if someone had any surgery, they feel that they may not be able to see a chiropractor anymore, or they even can't even do physical therapy. We do hear that a lot of times from patients, and I don't know exactly where they get that misconception from. Obviously, we're going to take the patient's condition, the patient's history into account, and we're going to modify our care accordingly.
Yeah,
Correct.
We're not adjusting those fused segments.
That's right.
If a segment's fused, we're not going in there trying to get cavitations, and we're not going to try to move the one above it and below it to, I mean, they're fused together. We're not doing that, but there is a spine above it and there's a spine below it, and those areas of the spine need to be addressed because we don't want extra wear and tear on the rest of the spine because that spine is now fused in that area. So the body starts compensating.
That's correct. And even at that area where it's been fused, there is sometimes inflammation at that level, particularly at the superfascial level. There can be some inflammation there that can be manipulated to help decrease the edema and also give the patient some pain control, particularly in the acute setting.
So let's work our way up. So again, you start with conservative care, physical therapy, chiropractic care, aquatic therapy, all sorts of different conservative treatments. And then what's the next line of defense for you? You said a lot of times you'll do injections and things like that, right?
That's correct. And the purpose of the injections is to help decrease the inflammation around the nerve root and also can shrink the disc down a little bit.
And what's usually in the injections?
Usually in the injection there's a short-acting or a long-acting anesthetic which we use to anesthetize the skin. But the combination of a long-acting anesthetic plus a steroid helps to give a little bit longer acting
Reduce
effect.
the inflammation.
Correct.
Sure. And we definitely see that can have some profound results with a lot of patients as well.
Correct, particularly in patients with radicular symptoms, pain which starts in the neck, radiates down the arm, into the fingertips, or it starts in the low back, radiates into the lower extremity, and into the foot.
And that's a common term, and that a lot of people don't necessarily realize that a lot of times when people get radiculopathy or radiating type of pain or numbness, a lot of times we'll see patients come in and think there's a problem in their hands or a problem in their arms. It's really coming from the nerve roots that exit out of the spine and come down through the arms. And then same thing with the back. They'll think they may just have numbness or tingling in their legs, that it's a blood flow issue 100% of the time, whether it's a problem in their knee or their leg. And it's actually a lot of times from the nerve root in the lower back where it exits the spine and comes right down through the legs.
Correct. And some patients will use terms that they may not use an elaborate term such as radiculopathy. Particularly in the lower extremity, they may use a term such as sciatica.
I have sciatica right here.
Yeah. I think I have sciatica in my arm. I'll hear people say all the time.
That's right.
What that really means, too, I'll explain that to our audience here. These bottom couple of nerve roots, they come down and they form a nerve here called the sciatic nerve that runs down the back of the leg. And so the symptom, sciatica, is when there's pain or numbness or tingling through the bottom, or burning sensation even through that sciatic nerve. It doesn't really come from the nerve here, it comes from the lumbar nerve roots in a majority of the instances.
Correct.
Yeah.
But we do hear a lot of people say it's in different parts of their body, and really that's the sciatic nerve is just in the back of the leg there.
Yeah, and it's
Correct.
cool, like there's like simple orthopedic tests that you can do, and people have had numbness and tingling in their arms, down their hands for their whole life, and you just lift up on their head and they're like, it's gone.
Right.
What is that? Oh, I thought I had to live with this my whole life. I thought my hand was, I thought my arm, I thought all this stuff. We're like, that's coming from your neck.
Correct.
Everything from coming out of your nerves, that's controlling everything out here. So you have to go to what's the cause more than just, hey, let's treat these, treat my numb fingers.
The symptoms, right? Now
Yeah.
you're going to cut
Correct.
the arm off or put lotion on the arm or things like that. We want to get to the root where it's coming from.
Correct. And sometimes if they elevate the arm over the top of their head, that will help to reduce some of
Yeah.
that radicular pain that they have in the upper extremity or some of that numbness in the upper extremity. So, yeah.
So let's talk about some of the great technological advances in imaging. And now that most things are digital, do you do X-rays in your office?
Correct. We have a full digital PAC system. We have a full complement of EMR and digital packaging and software. Patients can actually go to our website at spinemi.com, or they can click on the ZocDoc app, and they can actually go in and make their own appointments if they'd like, or they can simply call our number 248-792-9496 and ask to speak to one of our secretaries, and they'll be happy to get them scheduled, and we'll be happy to get them treated.
It's really cool that it can be right online. It makes it easy to access records and communicate with other physicians that you're co-managing with as well. Is that correct?
That's correct.
Yeah, with electronic health records these days, I mean, before you had to wait for snail mail to, hey, I need this patient's records. 3 weeks later, now you're seeing why this person's in your office. Now, a quick email, everything, I mean, everything expedited now with the way technology is. And like you said, making appointments online is incredible. That's what I have for my website as well, is patient can go on there, schedule a consultation right there on the website.
That's correct.
And it definitely speeds up everything. I mean, getting the patient in the door, you want to be able to start taking care of them, not worrying about everything else. So if they can fill out their forms online and all that good stuff. So technology is definitely taken the medical profession to the next level.
That's
As
correct.
far as records go, it's really important for physicians to communicate, especially when there's a case where you have multiple different physicians and someone may have an orthopedic and a rheumatologist, a chiropractor, a neurologist, and so it's really good in that sense to keep everybody informed on what everyone else is doing.
That's correct.
Yeah.
And typically for us, a copy of the note is faxed as well as mailed to the referring physician. If the physician needs a phone call, or if they can easily call me directly on my cell or text me if they have any questions about their patient.
Yeah, that's another cool thing, cell phones, you know.
That's right.
People,
Yeah.
I mean, people used to be so scared to give out their phone numbers.
Right.
And I mean, I give my patients here, if you need something, don't call 911 first. I mean,
Right.
it's not, unless it's a super emergency, I mean, having a direct contact with the patient is huge.
That's right.
I mean, if they need something, being able to be there to answer a question, I think that's awesome.
That's
So we talked about the X-rays and the digital X-rays and how that's so much easier without a dark room, without having the big films to file and to pull up on a light box. We have the same thing. We have a digital X-ray system in our office, and actually we have a video X-ray, which is really cool. We can, instead of taking just a static film, we can actually take a motion digital cinematography, and we can see a whole lot more where there's restricted motion, where there's ligament laxity, all sorts of things, which is really cool. But if you could explain maybe the differences between an X-ray and an MRI, most patients think they may be interchangeable, and there's a big difference between an X-ray and an MRI.
That's correct. I mean, an X-ray is a two-dimensional film that highlights bone. An MRI is a three-dimensional film that really expresses and really defines the soft tissue, particularly if we're talking about the spine. We want to know what's going on with the spinal cord, the nerve roots, as well as in the lower lumbar spine. We want to know what's going on with the nerve sac.
Yeah. It's very cool technology. And how the way it works is like slices, like you're slicing a loaf of bread, kind of. And they take it like this, and each picture is different slices. They can take top, sides, different ways, and we're looking at actual slices. So you can see a whole lot more and can see soft tissue. And would you say, just like you said, you start with most patients conservatively, and then you advance through the system? Would you say, as far as imaging goes, X-ray is usually the starting point, and then we move to an MRI?
That's
It's a little
correct.
less conservative, and we can see a lot more with it. It's
That's
a little more
correct.
costly procedure, so if we don't need it, we don't always do it, but when we do need it, it's the really standard for seeing soft tissue injury, spinal cord lesions, all sorts of different things.
That's correct.
So we have a few models here that you brought. You brought this model of my favorite part of the spine, the cervical spine. I see this model has a fusion already in it. Will you explain to the audience about how this fusion and the process works? If the person has gone through the whole thing and now they need the surgery, how that procedure goes?
So basically, if the patient has exhausted their conservative care with either chiropractic care, physical therapy, or aquatic therapy, they've had a trial of nerve blocks, which would include the epidural steroid injections or facet injections, and they still complain of neck pain in this particular case and pain radiating down the arm, then at that point in time, the patient is typically deemed as a reasonable candidate to undergo. For this particular procedure, this is what's called an anterior cervical discectomy and fusion. And what that means is basically we remove the disc or the soft tissue structure that separates one vertebral body from another. Okay, this also provides the anterior column support for the spine. Once we remove that disc material, then basically we're looking at what's called the posterior longitudinal ligament. This is a covering that covers the actual spinal cord. Now sometimes disc herniations can actually get behind that posterior longitudinal ligament, causing further compression of the spinal cord or the exiting nerve root. So in most cases we take down that posterior longitudinal ligament to further decompress the spinal cord. But we also take down the bone, and we actually follow out through the foramina, and we try to decompress the axilla of the nerve root on either side, either right or left. But we have to pay careful attention, and this is all done under microscopic guidance. So we're looking at this under a microscope, because the last thing you want to do is get into this red structure, which is called the vertebral artery. So once you've thoroughly decompressed the spinal cord as well as the nerve roots, we put in a spacer. You can kind of see it behind the green plate. This spacer is called a cage. That cage is usually filled with a graft material that inducts or promotes fusion between one vertebral level and the next. Once that's complete, then we actually put the plate on and we lock it into position. The plate, they'll have what we call variable angle screws, meaning that they're angled superiorly, but as this starts to fuse and heal, those screws start to migrate inferiorly, and that helps to provide further compression of that particular cage. The patient typically wears a soft collar for about 6 weeks, and the pain, the first thing that the patient will notice after undergoing a procedure like this is that the arm pain is the first thing that goes away.
Awesome.
And you could tell our audience too, so when you do a surgery like this, where do you go in from?
Basically, we make a transverse incision, and we go between this muscle, it's called the sternocleidomastoid, and the actual throat. There's a fascial plane that we follow down all the way until we get to the anterior aspect of the spine.
That's awesome.
And then I'll pull up this other model here. We can kind of look at this one here. These two. So here we have a model where we see a bulging or a herniated disc. And if you think of this disc material in between the vertebrae, kind of like a water balloon. If I was to slowly squeeze a water balloon before it would break, it would bulge. It would take the path of least resistance, and you can see here where the disc is bulging and how it can irritate on the nerve root. And so that one, what he was talking about there, is what they'd call a full discectomy. Now, if you could explain maybe a partial discectomy and how you guys go about that as well.
Correct. So basically with what we call a laminectomy or a hemilaminectomy, just meaning that it's half of the lamina. And in that particular procedure, it's done through a minimally invasive approach, very small incision. We can perform this either with a laser, or we can perform this just utilizing excuse me, the standard burr, where we remove the lamina. We can undercut the actual foramina and create more room for the exiting nerve root, which is the yellow structure. Again, once we remove a portion of the lamina, there's a ligament that covers that the big yellow structure is called the nerve sac or the thecal sac. We remove that ligament, and then that exposes the actual nerve sac. Once you've exposed that nerve sac, you can gently retract it over, and basically what you'll be looking at is you'll see a lot of inflamed disc, and basically you can identify the disc, and you can remove the disc with a small blade and some instruments.
That's awesome.
And would you say that's a little more conservative than the full fusion, would you say?
It is. It's more conservative than the fusion. Those patients typically, they're up walking the next day. They're out of the hospital the next day. Some patients go home the same day.
And in that case, you don't go through the same site, right? You go through the posterior aspect?
This is, well, the model that you have is actually the lumbar area. So we're talking about the low back area. For this is incision that's slightly off midline. It's not directly midline.
So after a procedure like this, we have this instrument this chiropractic instrument is called an activator. So you're saying, you have a lot of inflammation, and you want to make sure the patients get under chiropractic care to help with the reduced inflammation, the muscle aspect, the bones above and below it. So this instrument is actually used, I'll use it on your finger. Let me see if you turn around like this. I mean, it can feel as little as that, or you can go way higher and have a lot more pressure. So this thing can adjust a little baby's bone all the way to a grown adult. So this instrument does a lot of work for muscle aspect, like you were saying. What the chiropractic care that's needed after a surgery like that.
We'll use that a lot of
That's
times
correct.
post-surgical to be a little more gentle and conservative as well with someone who has had more recent surgery.
Yeah, more specific, using an instrument, so we're not messing with those fused vertebrae. We want to make sure that it heals properly and everything like that. So.
Now, when you do perform surgery on somebody that looks more like this, now we just talked about the discs like a water balloon. Now if we think of it more like a sponge, when a sponge starts to dry out, it loses some of the height. And then what happens is the body recognizes instability around the disc and lays down calcium or bone growth, which we call osteophytes here, osteophytic formation, or bone spurs is more of a common name. When you go in and see something like this while you're replacing the disc, do you guys take the bone down a little bit as well?
Well, in this particular instance, the only way we would see, this is the anterior aspect of the spine. The only time we would actually take this bone out or remove these osteophytes anteriorly is if we were performing an anterior procedure. An anterior procedure or anterior approach to the spine is typically called an anterior lumbar interbody fusion. And there's one other instance that we'll perform an anterior approach to the spine, and that's if we want to perform what's called an artificial disc replacement. In that particular patient, we're looking for patients with a disc that's injured without posterior degenerative change. In other words, there's no posterior osteophytes. The patient has reasonable facet joints, and we go in, anterior approach. It's called a retroperitoneal approach, which means that we're not exposing the intestines or anything like that. We follow that fascial plane. At L5S1, we have the iliac vessels that we work through. If it's more proximal, we have to take down the iliolumbar vein, and then we can easily retract over the aorta and the vein.
You mentioned disc replacement therapy. Was that what you said?
Well, it's a disc replacement surgery. And in that particular case, we're actually removing the disc. We're replacing that disc with something that moves. It provides motion.
This is a new technology, right? This is fairly new?
It's fairly new.
Yeah.
I mean, our fusion technology is a little bit older technology, but the artificial disc replacement has been around since the early 2000s.
Yeah.
At
And you
least
do
our
that
clinical
cervical spine as
trials.
well, too?
You can also do it in the cervical spine as well. And this is a motion preservation procedure. And this also helps to prevent what's called adjacent segment disease, which typically you'll see after fusion after approximately 7 to 10 years.
I know we have only the lumbar models here, but when you do the cervicals, when you go in to do the replacement like that, you do take down the bone on the osteophytic formation in the anterior compartment. Is that correct?
That's correct. Correct.
So you're dealing with, how much percentage of your patients do you think actually don't need surgery to go through the preventative care, and that helps more? What is your surgery rate, would you say?
Oh, I only operate on approximately 10% of my patients.
10%.
I'm able to help a lot of my patients get at least 50% pain relief with non-invasive techniques.
That's great for the audience. I
Yeah,
mean,
and-
here we have an orthopedic surgeon saying only 10% of his patients actually need the surgeries. That means 90% of your patients are getting relief prior to that. So
Correct.
that's great for the
And
audience
that
to hear.
is even better than 10% because the patients he sees aren't people just fresh off the street that are coming in for a physical exam. He's only seeing people that are referred in that already have been referred to him, usually by primary care physician or other specialists, not necessarily just someone coming in saying, you know, I just tweaked a muscle here or anything like that. So 90% of those people that are already referred to orthopedic spine specialists don't necessarily need surgery.
That's correct. And a lot of those patients, we can help reduce their pain with the conservative care of nerve blocks and spinal cord stimulators and these types of things.
Yeah, that's
So
great.
you just mentioned spinal cord stimulator, and I see you brought a model here too. If maybe you could explain that to our audience as well.
So basically the spinal cord stimulator, this is technology that's newly advanced, and basically what the stimulator does is that it sends out neural impulses that blocks the pain at the spinal cord level. Typically it's a 5-day trial for the initial procedure. In that initial procedure we find an interlaminar window typically at about T12 L1 or L1 L2. The T12 L1 level is if you feel the last rib that you have on your side and just slightly inferior to that, and you follow that to the midline of your lumbar spine, that's approximately the area where we'll perform the trial stimulator. And basically the way we perform that is that we take an epidural needle, we insert it into the interlaminar window, utilizing a loss of resistance technique. Once we're in the epidural space, then we place 2 leads on the posterior aspect of the spinal cord, approximately at T7, T8, and T9. That connects to an external battery, and the patient wears that external battery for approximately 5 days. And what we're looking for is that we're looking for patients that we can achieve greater than 50% pain relief in the lumbar spine as well as the lower extremities.
I mean, 50% pain relief, that's huge.
Well, yes, that's very huge. I mean, you have a lot.
That's life-changing.
Correct. You have a lot of patients with chronic pain issues who've either had previous back surgery or maybe they have not had back surgery at all, but they want the least invasive procedure that they can have.
Sure.
They
So
don't
is
want a
this-
fusion.
Is this another thing you do before surgery on most of your patients, or this is?
Correct. This is an
Okay,
option
this is-
for my patients. So if the patient has had previous back surgery and they have post-laminectomy syndrome, meaning that they have chronic back pain, continuous leg pain after a lumbar or cervical surgery, the spinal cord stimulator is an option. If the patient has, let's say, a herniated disc, but let's say the patient can't take time off work, but we can perform the spinal cord stimulator that can give them the pain relief that they need so that they can go to work, they can be productive, they can be active with their kids, and have a better
It's great to
quality
have
of life.
options. This is really great to have options that you can explain to the patients, and you know, there's no one answer for everybody.
That's correct.
And there's probably less side effects of this than, let's say, putting them on 10,000 prescription drugs to kill the pain.
Correct. And I always inform my patients that the pain medicine, there's no pain medicine that takes pain away.
Yeah.
Pain medicine does
Makes
2
it-
things. It makes you sleepy, or it can give
Not
you some
care.
type of psychosis
Yeah.
where you're imagining things.
Absolutely.
So let's just talk for our last few minutes here. As chiropractors, we're really big on prevention rather than just crisis or emergency care. And from an orthopedic standpoint, what are some things that people can do at home to prevent injury, to prevent maybe degenerative changes, things like that? I know we were talking briefly before the show about snow shoveling, as today was the first snow of the season.
Correct.
What are some things people can do at home to be proactive?
Well, number one, I think patients have to look at their body as a temple. Number one, it starts with what kind of diet that you have. So diets that are have a reasonable amount of calories. They're not eating late at night, particularly eating things that are high in calories, such as cake and.
But it tastes so good, Doc.
I know, but the excess weight gain, you have to strengthen your abdomen. You have to strengthen the paraspinal muscles. The paraspinal muscles are just the muscles that lie to the lateral of the spinous process. If you palpate the spine in the middle of your loved one's back, the muscles that are to the right of that and to the left of that, those are the paraspinal muscles. And you want to keep those strong. If you are not in a formal exercise program, you can always visit your local chiropractor, particularly Dr. Rodnick, and he can show you some exercises that will help you to help strengthen those muscles.
And that's something, like I said, we're very big on being proactive, preventing damage, preventing injury. And that's why we recommend to our patients to come in for some irregular chiropractic checkups to see how their spine is working and to have chiropractic adjustments preventatively, not just for when they're in severe pain.
Yeah,
That's
keep their
correct.
spine
Yeah,
as
we don't
healthy
like our
as we can.
patients crawling into the office. I'd
That's
rather
right.
them be under care and then the symptoms never occur.
Right.
I mean, if we're taking care of causes, then there's no such thing as a symptom.
That's
So
right.
I'd much rather my patients be under routine checkups of care than ever see someone have to crawl in.
That's
And
right.
we'd also, when they do have symptoms, encourage people to get a checkup, whether it's from their primary care physician or their chiropractor or orthopedic. But don't wait and let it get worse and worse, because by the time that happens, they may have more degenerative changes, more nerve root compression, all sorts of things. So when they do start to feel something, don't hesitate to get a professional opinion.
That's correct.
Yeah. Proactivity.
Right. And it's preventative care.
Yeah.
I mean, you can't work, you can't perform your activities of daily living if you don't have a healthy neck, a healthy back, and these
Healthy
things.
nervous system.
That's correct. If your back's in some form of dysfunction, particularly with your facet joints, if they have some form of segmental dysfunction, they need some form of adjustment to help relieve the pressure on the sensory nerve that innervates those facet joints.
Absolutely. Well, thank you so much for joining us.
Oh, thank you. Thanks for
And that's,
having me.
Absolutely.
That's all the time we have today. This has been Ask the Chiropractor. We're here with our special guest, Dr. Lou Radden out of Bingham Farms, orthopedic spine surgeon, and our co-host.
Dr. Ruvayn Rubinstein out of Troy, Michigan.
And I've been your host, Dr. Adam Rodnick out of Commerce Township. Remember that God gave you the gift of life, and what you do with that life is your gift back to God. We'll see you next time on Ask the Chiropractor.